We're happy to welcome Dr. Melanie Honig back to the course today. Dr. Honig is a nephrologist at Beth Israel Deaconess Medical Center and an associate professor of medicine at Harvard Medical School. She has been a celebrated teacher in nephrology, both at a local level and a national level for many, many years. She's been the course director for renal physiology and pathophysiology at Harvard Medical School for over 2 decades. She's the editor of the core curriculum feature of the American Journal of Kidney Diseases, does a podcast on Burton Rose's clinical physiology of acid-base electrolyte disorders, and has received multiple teaching awards, including the Donald Selden Award from the National Kidney Foundation. She's a wonderful teacher, has been a mentor to me in my teaching, and I always look forward to her speaking. So thank you very much, Dr. Honig, for starting off the course on such a high note today.
Great. Well, thank you so much for having me. And I forgot to tell you not to do a long introduction. So thank you for that. Very generous of you. In this session today, what I'd like to do is go fast and furious through the nephron, thinking about physiology and also a lot of multiple choice questions. I have 8 plus a bonus. So look alive. We're going to go through those. And let's see if I can get this to go forward. Yep, and you heard about that. Here's my disclaimers. This is my objectives, and here we go. Okay, question number 1. So, in 2019, Credence thrilled the nephrology community. I know I went out and got a Flozinator button. So Credence was the canagliflozin and renal events in diabetes with established nephropathy clinical evaluation. I love how they thought of that name. And of course, since then, multiple studies have shown this effect. And so what you see on the left, the blue line is canagliflozin, and the tan is placebo, and you can see that in short order, the urine albumin to creatinine ratio in these patients, they had over 2,000 in each arm, dramatically improved. And on the right, we see time on the x-axis, and we see the change in estimated GFR. Okay, and so in the blue line, what you see immediately is a sharp drop in estimated GFR and a flattening. So that was the shocker. So here's the question. Which of the following is the most likely cause of the findings that were seen in this study? Was it A, afferent arteriolar vasoconstriction, B, afferent arteriolar vasodilation, efferent arteriolar vasoconstriction, or thinning of the glomerular basement membrane? And so I'll give you a few seconds to do that question, and then we'll see what we got and take you through the answers. I wish I had like some Jeopardy music at this point to look at that, but I'm seeing that most of you have narrowed it down to A or B with a few other choices. And if you're taking the boards, one little test-taking trick, if you see opposites, then often one of those is true. So you can kind of hone down on that. So let me take you through some of this. We use these medications all the time, and this is an excuse for me to go over the determinants of glomerular filtration. So this is a single nephron GFR, the formula, which or SNGFR, which takes into account hydraulic conductivity of the membrane, the surface area, and the difference between the hydraulic pressure, which you may also know as hydrostatic pressure, and the colloid osmotic pressure or oncotic pressure. So the difference between pressure and oncotic pressure times hydraulic conductivity and surface area. And as you know, and I'm saying hydraulic pressure because that's the pressure of moving through a tube, if you will, or blood vessels, whereas hydrostatic pressure sort of stagnant, although in fact we all use the term hydrostatic pressure. I've been known to slip that in, but hydraulic's probably more correct. And so you can see systemic blood pressure is changed and lowered by the resistance of the arteries, first the interlobar artery, and then a big drop with the afferent arteriole, and another big drop with the efferent, whereas the pressure in the glomerular capillary is rather constant throughout because of the factors on this resistance vessel. And so on the left, we have peritubular capillary and ordinary capillary, and on the right, glomerular capillary. And you can see that the pressure throughout the glomerular capillary stays rather constant and is much higher than an ordinary capillary to allow for filtration. And then we have the rising oncotic pressure as the filtrate is removed from the glomerular capillary. And if it got to this point where they were equal, then there would be no filtration. In truth, in real glomerular capillaries, we never get to that point, but that would be the place where that might happen. And so, as you know, the kidney maintains filtration over a wide range of perfusion pressures, not every perfusion pressure, but over a wide range. And it does that with these factors. So we have, here's the juxtaglomerular apparatus in close-up. And so if there's a low flow to the afferent arteriole, that leads to renin release. And you know that these cells are mechanoreceptors. Normally, when flow in the afferent arteriole is normal, those cells are sort of snug. And if the flow is low, they can relax a little bit, and that leads to release of renin. You can also, of course, have release of renin from the sympathetic nervous system, which touched down on those cells. And so when if there is low flow, that will stimulate renin. And we also have tubuloglomerular feedback. And so that is if low flow comes to the macula densa, that will prompt the release of vasodilatory prostaglandins, and that will cause dilation of the afferent arteriole. Okay? In contrast, if there's high flow in the distal nephron, that leads to constriction through adenosine over here, and that would then decrease GFR. So how does that translate to these medications? Well, in the diabetic nephron, there in the picture on the left, which was in this study in Credence, we had lots of glucose and sodium, and there is increase in sodium reabsorption along with glucose, and that leads to decreased distal delivery of sodium chloride, and that would feed back to the macula densa to increase GFR, to increase glomerular pressure, to maintain filtration. So if there's an SGLT2 inhibitor, then that would decrease sodium chloride reabsorption, increase distal delivery of sodium and chloride, and that would then signal the glomerular pressure at the macula densa to vasoconstrict the afferent arteriole. So that was the desired answer. And this isn't just my imagination. This has been shown in these cute little diabetic mice who were given empagliflozin, and 30 minutes later they measured the caliber of the afferent arteriole. So you can see on the left, this is the arrangement, and then after the medication, these arrows are closer together. That might be hard to see, so I have this graph showing the change in diameter of the afferent arteriole. And so what we're seeing here then, because of that vasoconstriction, then there's a lower GFR. So that was the desired answer. And, you know, there's a range of other benefits from the SGLT2 inhibitors, including, and I think this is so interesting, turns out SGLT2 inhibitors share a common scaffolding protein with the sodium hydrogen exchanger, NHE3, which we'll highlight in a few moments, but I think that's really cool. So it may be doing much, much more, as you've heard. Okay, so A was the desired answer. Let's go on to This is a 35-year-old man, and he is evaluated for darkened urine. He's using PrEP, the pre-exposure prophylaxis for HIV, for several years. And on exam, he's well, has a normal blood pressure, and I've given you quite a few labs. And I don't think this is such a mystery, but let's just look at those labs for a moment. I'm noticing that the potassium is low, the serum bicarbonate is low, BUN and creatinine are high because there's reduced kidney function, and the phosphate is low, and the uric acid is low too. And these two, and frankly, the potassium being low, it's pretty unusual for somebody who has a decline in kidney function. And so that makes you think, of course, of losses. The urine pH is not, it is low, appropriately so. And we'll get back to that in a moment. There's no blood, there's trace protein, and there's glucose. And then you can see the protein to creatinine ratio and the urine albumin to creatinine ratio. Of course, the units are different by 3 orders of magnitude. But I would expect when there's glomerular proteinuria, I would expect the urine albumin to be more than 50% of the protein, and that's not the case here. So there's some other protein, and of course you're familiar with that concept with the idea of light chains, but that can also be true with tubular proteinuria. And so the question here, what's the most likely cause of these laboratory abnormalities? And we have the classic distal RTA, the proximal tubulopathy, or the type 4, and it looks like most of you have chosen B, a proximal tubulopathy, which I've been hinting at. And you might have been bothered by the pH being low, even though this is a renal tubular acidosis. But in the proximal RTA, once you get to a certain threshold, here 16, 17, something like that, then after that, there typically is no further bicarbonaturia because you're below the threshold, and distal nephron can pick up some of the bicarbonate as well. So that would be typical. So this is really a classic proximal tubulopathy. And so this is a question just to highlight how rockin' awesome the proximal tubule is, if you will. So this is a classic study from Rector, and on the y-axis you see a ratio, the tubular fluid to the plasma fluid. So this is measured initially, and then at the end of the proximal tubule. And so initially, the tubular fluid and the plasma fluid are the same because the initial filtrate right after the glomerular capillary is just as exciting as serum, okay? Same features, all the same stuff. And then as you go along the length of the proximal tubule, you can see in short order glucose and amino acids and bicarbonate are reabsorbed so that the ratio becomes lower because there's less in the tubular fluid. You can see that. The sodium stays roughly the same because there's near isotonic reabsorption. There's lots of sodium reabsorption. Over 65% of the sodium is reabsorbed, but it's near isotonic. So we see that the number looks roughly the same. And inulin's not reabsorbed, and so whereas water is, and that's why the concentration of that goes up. So this is just to highlight the rockin' awesome proximal tubule. And then we often focus on this feature of the proximal tubule, which is the sodium hydrogen exchanger here that I just mentioned a moment ago. And this exchanger, of course, is important and frankly is the big player in sodium reclamation in the tubule. There's lots of sodium transporters, but this is the really big player. And so initially, when there's bicarbonate in the initial filtrate, the sodium hydrogen exchanger will swap a sodium for a hydrogen. And of course, meanwhile, the sodium potassium ATPase on the basolateral side is keeping the sodium within the cell very low. And so we have that exchanger, and then carbonic anhydrase that is on the brush border will facilitate conversion of hydrogen and bicarbonate to carbonic acid, and then to CO2 and water, which can be reabsorbed by the cell. Back in the cell, these are converted back to hydrogen and bicarbonate, and the bicarbonate is then moved into the blood with the sodium bicarbonate co-transporter with a pretty exciting stoichiometry to favor movement of sodium into that higher sodium concentration. Okay, now you may have also seen a graph like this before, and so this is, you could put these are sort of interchangeable in a way, the plasma bicarbonate and the bicarbonate reclamation, and this would be the line of unity. So any bicarbonate above, going up to roughly 24, 25 is all going to be reclaimed normally, and after that threshold, it's not reclaimed, and we have excretion of bicarbonate, and then bicarbonate would reappear in the urine, and the urine could be alkaline. So when there's disorder of the proximal tubule, as we saw here, that threshold may be a little bit lower. Now, the proximal tubule is a target for many, for toxicity of many medications, because these cells are also responsible for secretion of protein-bound medications like diuretics, frankly, and many other medications. And they do that with a pair of transporters, organic anion transporters and organic cation transporters, where there's a sort of a pas de deux, if you will, a dance where they're transported first at the basolateral membrane into the cell, and then out of the cell into the urine. And the older formulation of tenofovir disoproxyl fumarate, is rapidly converted to its active form, tenofovir, which is transported through the cell and toxic to the cell. And so, that is the mechanism for toxicity in the proximal tubulopathy. We used to think it was toxic to mitochondrial DNA, but in fact, it probably interferes with ATPase in the mitochondria. In contrast, the newer formulation, TAF, is very stable in plasma and doesn't form tenofovir, the toxic form, and also the dose is much, much lower, so transported to the targeted cells. And this is that the feature that it inhibits ATPase, which is complex 5 in mitochondria, and that's the form of its toxicity. Okay, so proximal tubulopathy. I think that question, not a real mystery. All right. Moving on, one more question about an HIV-containing medication, cobicistat, which is often used in combination with tenofovir in the medication Genvoya, for example, causes mild to moderate renal impairment and leads to a decline in estimated GFR. And this is a graph from an older graph from the company. This was it says estimated GFR in their report, but frankly, it was Cockcroft-Gault, so it's creatinine clearance. And there was a decline in creatinine clearance, and then washout and improves. And then this is actual GFR with iohexate, and there was really not a change. So what accounts for that difference, that alteration in the estimated GFR or estimated creatinine clearance with these medications? Is it effective arteriolar vasodilation? Is it organic cation transporter inhibition? Is it another proximal tubulopathy? Is it tubular intralumen obstruction? Because these are all strategies that I could imagine could cause toxicity from a medication. And so take a look at that, and I'm going to sip my coffee for 1 second. And I see that the majority of you have chosen B. I think this is a pretty straightforward question, but the majority of you have chosen organic cation transporter inhibition, and that was my desired answer. Indeed, cobicistat does inhibit organic cation transporters. So let's take a look at that. And so I'm showing those cells again. A moment ago, I showed you organic anion transporter effect from tenofovir, and there are also organic cations. And I'm showing cobicistat, but quite a few other medications do that, including dolutegravir, an integrase inhibitor, rilpivirine, we don't use that anymore, cimetidine, and of course our friend trimethoprim in Bactrim does that. Also, by the way, bicetegravir also which is in Biktarvy, also appears to do that. And by the way, I think also one of the agents in Zosyn may do that as well. And so something worth noting, that will increase the creatinine just a little bit, say 0.1 or 0.2, because of creatinine secretion is 10 to 20% of the normal creatinine excretion. And they're not additive. You don't get like 0.1 for Bactrim and 0.1 for dolutegravir and 0.1 for something else. It's just a one-time effect. Okay. So that was our desired answer. There are some medications that cause tubular intraluminal obstruction. Vancomycin is one such medication, and of course acyclovir could do that as well. So some food for thought. Okay. I think we're going to get a tiny bit harder. So maybe that was a warm-up. Here's my next question, question 4. A group of students, nephrology fellows rather, are celebrating the completion of first year by eating at a local restaurant, but unfortunately succumbed to symptoms of norovirus with nausea and vomiting. Several days later, one of them presents with malaise, weakness, and vomiting. And I've got some laboratory data for you. And one of the things that stands out is the potassium of 3. And you can also see that they likely have, I don't give you their nephrology fellows' renal function, but I'm hoping that most nephrology fellows have normal renal function at baseline. So I'm looking at, so they probably have acute kidney injury and they have hypokalemia. So I'm wondering, what is the most likely cause of the hypokalemia in our nephrology fellows? Is it A, potassium loss in the emesis? Is it B, secondary hyperaldosteronism? Is it C, shift of potassium out of cells? Or is it D, urinary losses with bicarbonaturia? I'm going to give you a few more seconds to think about that question, and then we'll see what you think. Okay, because I think this is a slightly harder question. And so I'm wondering what you think about that. And then I will take up the answer. And I can see like a little battle here going on in the answers. And so I wonder what you think. Can I make that bigger so I can see how much you're choosing? There we go. Okay, so let's go through this question and hopefully we'll give you some clarity. First of all, and I love old experiments because they did some crazy things and it helps us understand how things occur. So this is the electrolyte concentration in the gastric fluid of normal subjects. And this is like a gamblegram with electrolytes that you're accustomed to when you think about acid-base disorders in the serum, but at this time it's in the gastric fluid. And so what you're seeing here are, on the left, the cations, on the right, the anions, and you can see there's actually a fair bit of sodium in gastric fluid, and hydrogen, of course, and a lot of chloride, and just a little bit, the hatch marks are potassium. And so there's really only roughly 3-4 milliequivalents of potassium per liter in gastric fluid, which means that in order to have a potassium deficit, and when you see a potassium of 3, that reflects a deficit of, say, 1 to 200 milliequivalents of potassium, that it would take, a lot of maybe 50 liters of vomit in order for that to be the primary cause. And so that is not the desired answer. Okay, so remember that when vomiting develops, initially there is no volume depletion. Initially, there's just the vomit, okay? So initially, when there's some vomit, and frankly, this is even true initially, just with the alkaline tide, when you make acid, when the parietal cells make acid, hydrogen chloride goes into the stomach, and a little bit of bicarbonate is in the blood, and that extra bicarbonate is simply dumped by the kidney. That's called the alkaline tide. And so initially, when bicarbonate appears in the filtrate, if you're over that normal tubular maximum that I showed you earlier, then that bicarbonate is simply dumped in the urine. But it doesn't go out alone. It goes out with a friend, a cation, either sodium or potassium. And so before volume depletion ensues, sodium and potassium go out with the bicarbonate, and so there's where you develop and this is the generation of the alkalosis, if you will, and this is where you develop the loss in potassium that leads to hypokalemia, okay? And so that was the desired answer. And I'm going to come back to some of your other choices a little bit later, okay? So that's why patients who have hypokalemia from chronic vomiting develop because the urinary loss with bicarbonaturia. And that would be true in somebody who has chronic vomiting for other causes like gastroparesis, or let's say disordered eating with other behaviors. You could have loss with bicarbonaturia. And we'll get to the other answers in a moment, okay? Now, next question. This is question 5. A 68-year-old man is evaluated for management of hypertension and long-standing hyponatremia. He's actually, this is one of my patients. He takes hydrochlorothiazide, lisinopril, and carbamazepine for the distant history of a seizure disorder. His blood pressure is 150/88 and he has no edema. He is not willing to stop the carbamazepine. A trial without hydrochlorothiazide does not improve his serum sodium, and the urine osmolality is 600. So we have hyponatremia with a urine osmolality of 600. So I'm hinting to you that this patient may have the syndrome of inappropriate antidiuresis. You'll hear about more later. Which of the following is the best intervention if you only get one drug? You know, in clinical medicine, you don't only get one drug. But which of the following would be the best strategy for this patient? And I've given you some choices. Should you add amlodipine? Should you begin torsemide? Should you prescribe chlorthalidone, a different thiazide? Should you restart hydrochlorothiazide since stopping it didn't help anyway? Or should you stop tolvaptan? What do you think? Which would be the best strategy for this? I think pausing and sipping my coffee is a great strategy to help you have time. Okay, so for this question, again, in real life, you can try one or more medications. You don't only get one, and so amlodipine would be a nice choice for his blood pressure. That's reasonable. It's one of my favorite go-tos because it's generally well tolerated in people with normal kidney function, although, of course, edema is always a problem, especially in this heat we're experiencing, which worsens that. C and D are really very similar options because they're both thiazide diuretics. E will not help the blood pressure, but would certainly help his tendency to hyponatremia and the syndrome of inappropriate diuresis. And that leaves B, which is torsemide, a loop diuretic, which what I was looking for so that we could talk about how the loop works. And so, remember that when you want to produce maximally concentrated urine, you need two things. One is, of course, the activity of vasopressin, but the second and often forgotten factor is maintenance of the concentrated medulla. So you know that the thick ascending limb, beginning at the thick ascending limb, after that hairpin turn, when we get to the cells endowed with the sodium potassium 2-chloride cotransporter, the nephron is no longer permeable to water, and so as you take sodium, potassium, and chloride out of the lumen into the medulla, if you will, it doesn't exactly work that way, the filtrate becomes more dilute as you go up back towards the cortex, and the medulla becomes more concentrated. And you need the action of the thick ascending limb to make maximally concentrated urine. If you don't have that, then over time you will wash out the medulla so that the maximal concentration of the kidney is only going to be roughly 300. So in fact, if you look at this graph, which shows the urine osm on the y-axis, loop diuretics tend to make the urine less concentrated or closer to 300. So if SIADH is present, then this can make management easier because it's much easier to manage a patient who tends to run around 300 with their urine osm than a patient who tends to run around 600, because it will allow them to drink more water or require less solute excretion to get rid of a water load. And of course, thiazides have the opposite effect. Thiazides interfere with maximal dilution, and so they tend to make the urine less dilute, which makes excretion of a water load harder. And so that's why I thought for this question, torsemide might be the best play, because it'll bring the urine osms down towards 300 and potentially help him with his blood pressure. If the patient's urine osm was already 300, the loop diuretics aren't going to help you that much, but still not a terrible play. Okay, so this is one of my harder questions. Let's see how we go. An 8-year-old boy is seen for evaluation of delayed growth. His blood pressure is 90/60. His heart rate, 96 beats per minute. And we've got some labs for you. All right. And so I'm looking at the labs and I'm seeing my question. And looking at the labs, what stands out is a very low potassium of 2.8 milliequivalents per liter. I've got also a low bicarbonate, or total CO2 is 12, very low. BUN and creatinine are normal for a child. And we've got the calcium of 9.9, this is normal. Alkaline phosphatase of 520. And then I've got some urine data for you. I see the urine pH is 6.5. There's no blood. There's trace protein. And now the urine protein to creatinine ratio is 0.1 milligrams per milligram, which is normal. And I've got a urine calcium to creatinine ratio of 0.3, with normal being less than 0.2. And in children, it's much more common to do the calcium to creatinine ratio rather than a 24-hour urine. And in kiddies, they also do this in infants. You can do this with actually you can put cotton. This is crazy. You put a cotton ball in the diaper and you can like squeeze it out into the cup to get some urine. A couple things are standing out, and I'll add, as you're working on this question, that alkaline phosphatase is very high to my eye, but is more normal for children, although it does raise some concerns in the setting of the pretty significant metabolic acidosis I'm seeing here. So I'm seeing a bunch of thoughts from the audience participating, and thank you for being such enthusiastic question answerers in short order. You're definitely my people, and we can be friends. And so just to get into these, I guess none of you are choosing chronic diarrhea, and I didn't mention diarrhea. I think that would be very mean of me to keep that a secret, but I guess you could ask. I think it's always important to ask the parents, not just, like any change in bowels, but I think it's important to specifically ask the parents to describe the bowel movements. And sometimes it can be a little hard for parents with a single child who are not accustomed to parenting, and they may not have seen something before, but that would have been mean on my part. But it is certainly true that chronic diarrhea could lead to features of a metabolic acidosis and hypokalemia. So that would have been mean of me, but it could happen, I suppose. Although that's a really low bicarbonate for that diagnosis. Hypocalcemic hypercalciuria, that was mean of me, because I don't think that's a real diagnosis. There is an opposite diagnosis, which is hypercalcemic hypocalciuria, and this patient doesn't have a high serum calcium, but that one was actually mean of me. I did make that up, so I'm sorry. Güdelman syndrome is a syndrome where there's a defect in the distal convoluted tubule. We're going to review in a moment, but that is manifest as a hypokalemia for sure, but with a metabolic alkalosis. And I did not give you the pH of the blood. Certainly, when there's a low total CO2, it could be an acidemia or an alkalemia. But this is such a low bicarbonate that it's for sure going to have at least a component of metabolic acidosis. So that's the most likely thing. And so by process of elimination, I have honed down on B, which most of you chose, which is the classic distal renal tubular acidosis. So I'm sure you're going to hear about this more later, but here's my take on that disorder. So here I am in the distal nephron, and what you're seeing are two population of cells. And I'm envisioning myself as like Miss Frizzle from the Magic School Bus, and we're in our little magic school bus driving into the collecting duct where there's two populations of cells. There's these flatter cells here, these flatter cells that represent principal cells, and these cells with these microvilli that are intercalated cells, most of which are the alpha intercalated cells. And so two populations of cells, and it's important to recognize that these cells hang together and their milieu with each other, their partnership matters. So here's a more typical schema of these cells, and what you're seeing then again on the top is the principal cell, and in the middle an alpha intercalated cell. And I've circled a couple things. So what happens here is normally the principal cell reabsorbs sodium, I think I have, and makes the lumen negative. And normally then, because the lumen is negative, you lose both potassium and hydrogen. And normally they're rather balanced. And you know this, anytime there's a distal delivery of sodium, as with a thiazide, for example, then you have loss of K and hydrogen, and neither is severe, okay? But if there's a defect in this cell where you can't excrete hydrogen, the lumen's still negative, you cannot maximally acidify the urine, and you have then profound K losses because this balance is off. And I gave you this example in a kitty with the classic distal RTA, but I could envision this happening, and it doesn't happen very common in adults de novo. If it does, sometimes we see it, say, in like a interstitial nephritis with like a Sjogren's situation, where they have, and some of these patients have been described to have an anti-hydrogen ATPase antibody that affects this cell. But otherwise, it's extremely uncommon. Board question, they love, these kiddos are very prone to kidney stones. And although the high alk phos might be typical in children, there's also, because of the metabolic acidosis during growing, there's release, or anytime, frankly, release of calcium and phosphate from bone. And that excess release of calcium for bone is a big burden burden, and that's why the urine calcium to creatinine ratio is a little high. There's a big burden of calcium, and that calcium that extra calcium phosphate can precipitate in a relatively alkaline urine. And so they have terrible kidney stones, nephrocalcinosis, and that can be a problem. They're very, very hard to treat because of this. And in the growing child, you really want to try and mitigate that metabolic acidosis to help with impaired growth. So that was our desired answer here, the classic distal RTA. Okay, 7. I want to get 2 more in. I have a bonus. You can look at it your own. I don't think we're going to get to it. Remember our poor renal fellows? Well, one of them is still feeling poorly and back to the ED. Now he's frankly hypotensive. And remember, he had earlier loss of potassium from bicarbonaturia before he or she developed this situation of volume depletion. Recall the laboratory data is here. And I'm wondering, what would you expect for the urine electrolytes? And this is one of those dread sort of arrow cases where you see all the arrows up and down. And I'm wondering, what would you expect for the urine data at this point now with our poor fellow who has been vomiting and has these lab abnormalities? What would you expect? What do you think in this situation? So take a moment. I know it'll take a moment to go through these questions. I'm going to give you that time, and I'm going to take a sip of coffee. There's a lot of movement on the screen in terms of guessing these questions. Okay, so I'm going to take you through the answers now. I know this was a hard question, but once I show you, all will be revealed, okay? So, remember I showed you the proximal tubular cell again. It's one of my favorite cells. People talk about it as the workhorse of the kidney. I don't really like that moniker. I feel like it's a sort of a symphony. There's so many things going on. It has to be well orchestrated. And I told you earlier that whenever there's excess bicarbonate, then if you go over that tubular maximum, that tubular threshold for bicarbonate, then the excess bicarbonate is simply dumped in the urine. However, when volume depletion ensues and we activate sympathetic nervous system, ADH, and also the renin-angiotensin-aldosterone system, then we have activation of Ang2. And Ang2 actually has a receptor on the proximal tubule and frankly acts throughout the nephron, but especially here where it stimulates the sodium-hydrogen exchanger, and that sodium-hydrogen exchanger will rev up and you will reclaim more bicarbonate than normal. And this extra reclamation means that you will limit the bicarbonaturia, and then the urine pH will not be high because you're going to reclaim above the normal tubular maximum. Okay? And then distally, even though aldosterone is on, so we'll have aldosterone on, I showed you this, that will make the lumen negative, that normally leads to K secretion, and so that's how we think about it. However, when there's very little distal delivery of sodium, then there's less of that factor, which we've historically called the aldosterone paradox, the idea that sometimes aldosterone seems to be a K-secreting hormone and sometimes a sodium-retaining hormone. And indeed, in hyperkalemia, then we'll normally do the effect I just showed you. And by the way, in hyperkalemia, when you're just eating potassium, Ang2 is not on, and you don't have activation of sodium reclamation, and you can do that effect. However, When Ang2 is on, that actually stimulates sodium reclamation not just in the proximal tubule, but also in the early DCT and also here. And then it inhibits ROM-K. In other words, the kidney leaves nothing to chance. So even though aldosterone is on, K excretion is limited. And you know this because when you see patients in the ICU who are hypotensive, they do not all have hypokalemia, and that's because the kidney leaves nothing to chance. And so we see this pattern early in vomiting. There's a lot of sodium and potassium going out with bicarbonate. The urine pH is high, chloride's low because you're vomiting. And late in vomiting, we have what we'll call electrolyte poor urine, because the bicarbonate is reabsorbed proximally, and we have a low urine pH. Some people call this paradoxical aciduria. It's not a paradox to you because you know that the kidney is awesome at reclaiming sodium and bicarbonate, and this is our maintenance of the alkalosis, and so we're seeing that here. And so that's why the desired answer was B, lower urine pH and electrolyte poor urine. Okay? And I'm going to just throw in my question 8. We won't get to the bonus. This is a 55-year-old man who's evaluated for hypertension. Dietary recall shows a diet very high in sodium and protein. He's got eggs and bacon, TV dinner, lunch, and meats. You recommend antihypertensive therapy, but he wonders, can I improve my blood pressure without meds? And he totally changes his diet. And the question is, why does it get better? And I've got all these transporters here for you to think about. I'm going over by a minute, hopefully, or two for you to do this question. And you can see different choices: activation of pendrin, basolateral K-mediated NCC, decreased GFR, or downregulation of ENaC. That's your question. And I see that you're choosing a bunch of things. You may have to go back over this question because my time is up, but I just want to point out we call the potassium switch. This is the distal convoluted tubule cell, and when I learned it, I only learned about this transporter, but it turns out there's a K sensor here. And so when K is high, because of a K diet, it doesn't have to be really high, just within normal and on the high end, that turns out to inhibit NCC, and then you have more delivery of sodium and chloride distally. In other words, having a high K diet is a little bit like having a thiazide diuretic, whereas if you have a very low K diet, that actually stimulates NCC and you have sodium retention. So that's why, and that's called the K switch. And I won't talk about pendrin. I hope you'll learn about it a little bit later, or I can answer it in the Q&A. And so that's why, but these are all written out for you. And that's why B was the desired answer. And so I'll just skip these questions, my extra question, and say thank you so much for listening with me. I'm sorry I went over a little bit. My enthusiasm hurt me. And thank you so much for joining, and have a great day.
All right, excellent. Thank you so much, Dr. Honig, again, for that wonderful talk and a great introduction to the course.